I'm Jason Kempenich. Here are my disclosures. I've been asked to talk about how the perceptions of autonomy differ in general surgery training between faculty, senior residents, hospital administrators, and the general public. At the heart of resident autonomy is trust. Ali Tenkade, the father of EPAs, points out that often faculty can identify which residents they trust, even if they have trouble giving concrete examples. Without trust, it is difficult to extend more autonomy to the trainee, and this underlies the entire issue. The degree of autonomy entrusted to trainees by faculty has a significant effect on others besides the residents and faculty they work with. Most importantly, the patients who are under their care, as well as the administration of the hospital, who are also accountable for quality, safety, liability, as well as standards of supervision for reimbursement. In 2013, the American College of Surgeons started their Transition to Practice program, now called the Mastery in General Surgery program. Their first cited goal was to help trainees obtain an enhanced autonomous experience in broad-based general surgery. In 2012, the Annals of Surgery published a report citing that 80% of residents enter fellowships as evidence of decreased autonomy. In addition, self-determination theory states that humans have a natural tendency towards autonomous behavior, and when we act autonomously, we learn better and achieve superior performance. With this in mind, we developed a survey and distributed it at 3 institutions to identify barriers to resident autonomy as perceived by the major stakeholders. And these are our results. We first published them in the Journal of Surgical Education and reported them in 2015. Here you can see the total responses from each group as well as our response rate. When asked if resident autonomy was required for developing competent surgeons, the vast majority of faculty, residents, and administrators in all 3 groups agreed or strongly agreed. Faculty and residents also had a high level of agreement that when residents have more autonomy, self-confidence improves. Conversely, they agree that when resident autonomy is decreased, sense of patient ownership among residents suffers. Reese Randall, interestingly, just published a multi-institutional study in the Journal of Surgical Research that showed that residents who have a high ownership score also rate their autonomy level as more appropriate and have improved markers for wellness. In our survey, all 4 groups were asked if residents should perform procedures independently prior to graduation. Fewer individuals in the general public agreed or strongly agreed compared to the other groups. However, if we look at the mean rank of all responses, we see that surgery residents felt that independent operative experience was more important compared to all other groups. Pairwise comparisons were also significant. 81% of the general public agreed or strongly agreed that residents should perform procedures independently prior to graduation. However, when we asked the general public if they would consent for a PGY5 resident to independently perform a routine procedure on their person, only 73% agreed or strongly agreed. The general public wants surgeons to be well trained, but some are hesitant to be part of the process. We then asked the general public for their view on resident participation in their care, and 96% were welcoming to residents. However, if this involved a routine surgical procedure, 82% of the general public would consent to resident participation. We then took it one step further. If the procedure was complex, that percentage dropped to 59%. In short, as we specified resident participation to mean involvement with a surgical procedure and then increased the complexity of that procedure, the general public was less enthused about resident involvement. If we compare the distribution of responses of the general public to faculty, senior residents, and administrators regarding resident effect on quality of care, we see that faculty, senior residents, and administrators all felt residents had a much more positive effect on the quality of care provided than the general public. Finally, we asked faculty and residents to rate the current level of autonomy at their institution. Most felt it was appropriate, but a significant portion felt it was too little. No participant surveyed in either the faculty or senior resident group felt there was too much autonomy at their institution. Based on these findings, we concluded that the majority of teaching faculty, senior residents, administrators, and the general public agree that autonomy in training is important for developing surgeons and has significant impact on surgeon confidence and resident ownership of patient care. Barriers to autonomy include the general public's hesitancy with resident operative independence, resident involvement with complex procedures, and resident effect on quality of care. Our data shows that knowing how much autonomy is appropriate for resident training is difficult to ascertain, and the groups do not agree. With that said, no faculty or resident felt residents were afforded too much autonomy. In light of the barriers to autonomy coming largely from the general public in our survey, we then embarked to see if we could improve patient perceptions of resident autonomy with education. We developed a pamphlet describing the roles of medical students, residents, and attending surgeons, and handed the pamphlet to all new patients in our outpatient surgery clinics. When all patients were surveyed, comparing routine and complex procedures, as well as junior versus senior residents, patients were most comfortable with resident involvement if they were a senior resident at 77% for complex operations, increasing to 82% for routine procedures. Experience of the resident and relative complexity of the procedure matter to the patient. In light of these results, I've encouraged our residents and faculty to identify chief and senior residents as such. I believe, and I think this data supports, that patients are most afraid of us unleashing a new intern to practice on them, and the sooner you dispel this concern, the better. When we asked patients if they would allow a fifth-year surgical resident to perform a procedure independently, 64% of those who read the pamphlet agreed or strongly agreed, compared to 52% in the control group. We were encouraged that a relatively minor intervention could produce a significant positive effect in favor of resident autonomy. Those results led to the American College of Surgeons producing this pamphlet that can be downloaded by anyone for use in their clinic. Multiple articles in the literature have called for early introduction of resident involvement in patient care. Given our findings with the pamphlet, we thought we should investigate the use of video media. We found similar positive results when educating patients in the outpatient setting. But interestingly, when using video education of resident involvement for acute care surgery in patients, many of whom were resident naive, there was not significant benefit. The most significant factor predicting favorable patient attitudes was the expectation that residents would be involved with their care. So what are the take-home points? There's near universal agreement among residents, faculty, and administrators that autonomy is necessary for training. Patients and the general public are very accepting of resident involvement. But surgery does have a unique challenge in that patients become more hesitant with the prospect of being operated on by residents. Patients are reassured when a more experienced resident is operating on them. And lastly, the earlier you introduce resident involvement, the better. And education in the outpatient clinic specifying resident roles and responsibilities can promote resident autonomy. Thank you very much for the opportunity to present.